Hello, my name is Anoop Kathiri, and I'm a neonatologist at Sharp Mary Birch Hospital in San Diego. And today I'll be talking about umbilical cord as a resource to improve neonatal transition. I have no disclosures. And so today I'm going to review the mechanism for providing a placental transfusion and also go over methods of how to provide a placental transfusion in newborns that require resuscitation. So I think most of us agree that delayed cord clamping is great for healthy babies, but I think part of what we need to think about is what happens in a healthy baby compared to a sick baby. And so to illustrate this, Satyan Lakshrima up in UC Davis has done some nice cartoons for my talk. And in here, you can see that there are four major drivers of placental transfusion. Up here on the top left, one of the biggest drivers of providing blood from the placenta to the baby is the uterus that squeezes around the placenta and with contractions can provide up to 100 millimeters of mercury. Down here on the left, you can see that spasming of the umbilical artery. So as the artery clamps down, instead of blood moving out of the baby, you're going to have a net flow of blood going into the baby through the umbilical vein. Up here on the top right, we know that spontaneous respirations, and we've seen this in animal model, that as the baby begins to breathe, you're allowing more pulmonary blood flow to increase and allowing blood to then enter the baby more easily when the babies are breathing and having a better transition. And then lastly, we need that heart to be pumping blood from the umbilical venous circulation into the pulmonary circulation to allow for that transition. And when all of these four things are happening, as baby is getting delayed cord clamping, they start to pink up and everything is nice and good. But what happens if the baby needs resuscitation? So if a baby looks sick at birth, the priority of the obstetric team is to transfer that baby as soon as possible to the neonatal resuscitation team. So what happens is now you're truncating or cutting off the normal redistribution of blood from the placenta to the baby. We know that 50% of the blood remains in the placenta in infants less than 30 weeks of age. So then what happens to these four drivers of a placental transfusion? Up here on the top left, if you have an emergency C-section, you're cutting through the uterus. We also know that more preterm babies are also often delivered by C-section due to maternal indications like preeclampsia. So having a C-section then reduces the benefit of that uterus contracting around the baby and may not allow the baby to get effective blood with delayed cord clamping. Also, spasming in the umbilical arteries doesn't occur if you have cord compression. That is, when the cord is wrapped around the neck, that thin-walled umbilical vein gets compressed while that thick muscular artery stays open. So now you're having blood flowing out of the baby into the placenta without any net blood going into the infant. And then on the top right, we know that babies who are preterm often have respiratory depression, also apnea. And so then the lungs are not going to fully open in those cases, and you're not going to have that receipt of blood into the pulmonary circuit. And then lastly, in a very severe case, you could have babies that have severe bradycardia or asystole, where now we don't even know if there's any benefit of delayed cord clamping if the heart has completely stopped. And so when all of these things or some of these things happen, and you might get the baby right away, in fact, though, you're getting a baby now that's relatively hypovolemic and might actually be harder to resuscitate than if they were given that extra blood from the beginning. And so the challenge comes down to when we do research is that all of the major trials are struggling with the sicker babies. And we saw this in the largest study published to date, the Australian placental transfusion trial that was published in the New England Journal of Medicine, which demonstrated that compared to delayed cord clamping, there was no difference in immediate cord clamping in any of the death or major morbidity outcomes when combined. They were able to find a difference in death, but overall, there was no major difference. And one of the challenges with this is if you look in the results of the study, is that the babies who received immediate cord clamping all received the intended treatment. 94% of those babies randomized to immediate got immediate, but only 73% of the babies randomized to delayed cord clamping actually got the treatment. About a quarter of the babies didn't. And the reason they did was because of clinical concerns about the infant. So an infant who's thought or perceived to be too sick by the obstetrician or neonatologist is now getting deprived of that benefit, and those sicker kids are not getting the intervention. And what do we know about sicker babies? We know that when we use SNAP scores or CRIB scores, which are markers of how sick the baby is at birth, using APGAR scores or how much resuscitation they need, the sicker the baby, the more likely they are to have a brain bleed or die. So why would we pick an intervention like delayed cord clamping that's so good for babies that's being selectively excluded from the sickest infants? And we see that in all of the recommendations to date. Whether in here in the United States, we have ACOG, the American College of Obstetrics and Gynecology, ILCOR, which is the international branch of resuscitation, EAPM for Europe, SOGC in Canada, and World Health Organization for many of the countries out there. All of them say to do delayed cord clamping, but if the baby is too sick or if it's not possible, you don't have to necessarily do it. So you're always, even from the governing body, saying that it's not really necessary for the sickest infants. So we need alternatives for these babies that cannot get delayed cord clamping. And what are those alternatives? Well, there really are three of them. One is to do resuscitation with the intact cord, that is keeping the baby connected still and not cutting the cord and doing the entire resuscitation on the mother. The second one is to cut the cord right away, but leave a long segment and bring the baby over to the warmer and then slowly milk the cord. And then the last one is keeping the cord connected and then slowly milking it toward the baby. And I have some videos of each of these. The first one here is an example from one of our studies of a baby who received delayed cord clamping while the baby was getting resuscitation or CPAP. So here the cord is connected. It's coming out of the uterus right there. And then you can see that after the baby's dried off and put a towel over, we're then providing the baby with some CPAP. And then the baby can get additional breaths if needed, or if the baby is apneic, there'll be a few breaths given to that infant. So in this study, half the babies were randomized to be receiving this intervention, so they weren't necessarily sick, but it was designed to test the feasibility of performing a resuscitation while the baby was still connected to their mother. And then here's an example of intact cord milking. So here you can see the cord is still connected to the baby, and then they are milking the cord towards the infant over here 4 times while the cord is still intact and baby is gently stimulated over here on the right. Then over here on the left, this was a video given to me by Dr. Hosono from Japan, where he showed now the baby has already been delivered and the cord has been cut and the baby's moved over to a warmer. And here you can see that they are, while the baby's getting oxygen and CPAP, they're slowly untwisting the cord, and then they'll slowly milk the cord all the way down until it's completely white one time, and that's called cut cord milking. Well, one of the concerns with preterm babies is how much blood can they handle, and this sort of idea of perfusion pressure autoregulation. We know that adults have a very wide window of autoregulation, meaning by a certain, there's a certain point where adults can no longer maintain brain perfusion, at which point they'll start dropping their cerebral blood flow. And the newborn is the same way, where there's a certain cut point as well before they'll start to drop their cerebral blood flow as well. For adults, it's at 60, and for term newborns, it can cut point around 40. The challenge we have is that the very preterm infant has an even narrow window of autoregulation. And in fact, the more preterm they are, the more they're shifted over here to the left. And that becomes a problem when we're looking at providing blood to these infants, especially if it's given rapidly. And one of the concerns with cord milking in an extremely preterm baby is that when you're milking the cord, you're not just milking blood sort of onto the venous side, you're also milking it to the arterial side. So here in a situation where the baby might be already getting a lot of blood flow, like with uterine contractions, as you're beginning to milk the cord, you're sending blood first up here through the umbilical vein, where you're going to get an increase in preload and maybe better contractility, but you're also going to be milking the cord in the umbilical artery, which is increasing the pressure in the descending aorta. Both of these are going to provide more blood to the heart, but also to the carotid artery. And in many cases, it might be okay, but there are situations where increased carotid blood flow in a very fragile situation, like a baby who has chorioamnionitis, so there's a lot of inflammation on board, also with extreme prematurity, adding these things together with fragile blood vessels in the very tiny infant might be dangerous, and in fact lead these babies to have a surge in blood into their brain and causing intraventricular hemorrhage. And this has been a theoretical concern, which has been seen in an animal model in 26 weeks lambs, where they demonstrate that milking the cord caused fluctuations in the carotid artery with cord milking, but these were not seen with delayed cord clamping. And so because of these theoretical concerns, the ILCOR body has recommended not to do cord milking in babies less than 29 weeks. And they were saying that even though milking might be easier to do, it's still, they are concerned about this theoretical risk of IVH. And really, there had been no data in humans to show this until very recently. And so we had done a study, or had started to do a trial, looking at cord milking in extremely preterm infants compared to delayed cord clamping as a non-inferiority trial, to look at whether or not these babies had abnormal outcomes with regards to IVH or death. And what we found in the study, as we were enrolling about a third of the way through, we had enrolled 474 infants, about 200 babies in each arm. And about a third of the way through, the Data Safety Monitoring Board said, we have found an adverse outcome that babies who were randomized to umbilical cord milking in the lower gestational strata had more severe IVH compared to those that are randomized to delayed cord clamping. They were important to note, though, there was no difference in the slightly older babies above 27 weeks in our cohort. And I'll show you the data here, which is when you look at the overall group, up here on the top, there was no difference in severe IVH or death. But when you look at severe IVH in the 23 to 27 week group, there was almost a 4-fold increase in severe IVH in these infants, but no differences in death, even by strata between the two groups. Now, when we looked at the characteristics of these tiny babies at 23 to 27 weeks, of course, babies with cord milking did not need to have their cord connected as long, so 20 seconds versus almost a minute. Fewer of the babies were crying or opening up their lungs and starting to breathe before the cord was clamped. And as we found an opposite result, that in fact, babies with cord milking had lower retinopathy of prematurity. And as I said earlier, there was that increase in severe IVH in these infants. So we looked at what other factors, and this goes back to that cartoon that I was showing you earlier, that in fact, what are some of the modifying factors of why some of these babies had severe IVH with cord milking? And one of the models that we did post-hoc was we demonstrated that the presence of chorioamnionitis on the placenta actually was a cofactor for developing severe IVH when you had cord milking. So here in the red line are the babies that received cord milking, and the blue line are the infants that received delayed cord clamping. And on the x-axis, the more preterm babies are here on the left, and the less preterm babies are here on the right. And so there's no difference in the more mature infants, but the 23, 24 weekers, there's this huge difference when chorioamnionitis is present. When you took away chorioamnionitis, there actually was very limited difference between these two groups. And that goes into the idea that maybe this sort of inflammation on top of getting the blood rapidly given to the infant might be enough to predispose these infants to severe IVH. The other part that we looked at was mode of delivery. As I said earlier, cutting through the placenta, you're not getting that benefit of squeeze. Cutting through the uterus, sorry, you don't get that squeeze around the placenta. And in fact, you might not get as much blood moving towards the baby. So during a cesarean section, there actually was not any difference in severe IVH. But when we looked at vaginal delivery, again, squeezing on the placenta and the blood moving into the baby, now you're milking the cord. That's a rapid change in those infants. In fact, the majority of our difference in our trial was seen in those babies randomized to vaginal birth and receiving cord milking. Again, almost a 6-fold increase in regards to severe IVH. So these are some of the other factors that we looked at that might have contributed even more to our findings. Now, on the other side of things, is there any theoretical advantage of milking the cord in these infants? We had done a study, this was a translational model, so actually taking human blood and actually putting it into mice, and then seeing whether or not in these mice that had completely irradiated their bone marrow, does the blood that is being milked have a different characteristic than the blood that's receiving delayed cord clamping? We actually found that in the blood itself, there were more mesenchymal stem cells with cord milking compared to delayed cord clamping, an equal amount of hematopoietic stem cells, but the mesenchymal stem cells were increased. And over here on the left, you can see the nuclei of the mesenchymal stem cells are here in red. Laminin is found in Wharton's jelly. And over here on the left is the lumen of the umbilical vein. And you can see a lot of the mesenchymal stem cells are found along the endothelium. So the idea of milking the cord might actually be sort of dislodging a lot of these mesenchymal stem cells into the circulation. And sure enough, in these irradiated rats that had wiped out their entire marrow, we found that the rats that had umbilical cord milking actually lived longer than the rats that had delayed cord clamping blood, i.e. these stem cells could repropagate the marrow. And sort of to illustrate this, this is another cartoon here looking at what could theoretically be happening with the stem cells in newborns, which is with delayed cord clamping, you are getting stem cells into the baby. Hematopoietic stem cells are flowing into the baby, going into the bone marrow, and then allowing them to make red blood cells, et cetera, as well as the liver and other organs. And that's great because hematopoiesis is going to be an important part of development in these newborn infants. But the idea with cord milking is, do you actually get a benefit when you're stripping the cord and actually dislodging these mesenchymal stem cells, which are actually a cell designed to help aid hematopoiesis? They help hematopoietic stem cells differentiate more frequently and live longer, so you could get an enhanced hematopoiesis. So the idea is with these mesenchymal stem cells, you get this big, robust hematopoiesis. So what does that translate into? It might translate into higher hemoglobins, which we've seen in one study out of England, that babies who had cord milking had higher hemoglobins at 6 weeks of age. Could it also translate into better neurodevelopment? And we only have our initial pilot data to date, which is in our first study, which looked at 130 babies randomized to milking or delay out to 2 years of age. Babies who had cord milking actually had higher scores. So, I mean, what does this really mean in regards to our new trial and this adverse finding of severe IVH? Well, we know that in the tiniest kids, milking was associated with severe IVH with a number needed to harm of 6. There was this questionable benefit of retinopathy, but it wasn't what our trial was designed to be powered for. So it could just be a random chance finding, but it was still something that was positive. In addition, there was no difference in death or any IVH. What we really need to know is in our current trial, were there differences in long-term follow-up outcome? Meaning, do the babies who don't have severe IVH, do they actually have a benefit with cord milking? Is there a benefit of milking babies who are slightly older that may not actually have severe IVH? That we don't know. And in fact, there was a study done at the same time as ours by Samantha Shirk in Ohio that looked at 200 babies from 23 to 34 weeks of age and found no difference in IVH and no difference in death. But our mean gestational age was 32 weeks. In our trial, we had 182 babies from 23 to 27 weeks with a mean gestational age of 28. So small babies clearly are affected with cord milking. The question is, what about these less moderately preterm infants, the babies who are slightly older, do they have a difference? And I think the other part to think about is in our trial, over 95% of these babies randomized to delayed cord clamping received their intended intervention. Compare that to the other trial. In the Shirk study, it was only about 80%. In the Australian trial that I showed you in New England, it was 75%. In the cord pilot that went out to 2 minutes, it was about 60%. If you allow these babies to receive a full 60 seconds of delayed cord clamping, there might actually be a better benefit in these infants, especially if you allow even the sickest kids to receive it. So that might be one of the reasons why we saw such a low rate of severe IVH with delayed cord clamping compared to cord milking. The other thing to think about as well is morbidities are not all the same, which is severe ROP isn't often thought about as a bad diagnosis for babies long term. We talk about IVH and brain bleeding as, well, this baby's going to have a poor outcome. But when you looked at the CAP trial, which was the caffeine study by Barbara Schmidt, and they followed these children out to 5 years of age, they found that in fact, severe ROP compared to brain injury or chronic lung disease or BPD had the highest odds ratio for predicting a poor outcome developmentally at 5 years of age. So ROP is something we do need to take seriously, and in fact might be a contributor when we look at our 2-year outcome data. So where are we at now? We are continuing to do the study. In fact, this number is older, up to 800 infants, and we're only enrolling babies from 29 to 32 weeks of age. So at the end of the day, we'll have a large sample of over 1,200 infants to look at their neurodevelopmental outcomes to see, is there a cut point where cord milking is still safe? We're not arguing whether it's better, but is there a group where you could still say that it could be safely done in a baby who cannot get delayed cord clamping? And again, that's still more to come. And you can see even with ACOG for future areas of research, this is still from our obstetrical group saying that we know that babies requiring resuscitation might benefit even more from placental transfusion, but their need for immediate attention raises questions about whether they need immediate delayed cord clamping or does cord milking offer a unique benefit? And that's something that we still need to continue to explore. And so when we look at cord milking in older babies or even term infants, the question is it safe in that group? And again, don't have a lot of large randomized controlled data, but there are lots of babies that have been studied in cord milking trials. all of them showing that it does pretty much the same thing as delayed cord clamping, which is it gives these infants additional blood and volume. And the question is, maybe the term baby might handle this blood very differently than the preterm baby. That is, when you milk the cord in a term infant, now instead of worrying about blood going over across the foramen of valley, you might actually have more blood going into the right ventricle, into the pulmonary artery, because now the lungs are starting to open. And now, because you have better cerebral autoregulation, also a more mature germinal matrix, you might actually have less risk of IVH in these infants. And we don't see a lot of IVH in term infants. So the blood volume, even if given rapidly, might actually still be okay. But we need to study this. And so we are doing a trial, which we're a few months away from finishing. We're around 1,000 babies currently, to look at in non-vigorous babies, babies who are too sick to receive delayed cord clamping. Is umbilical cord milking compared to immediate cord clamping better for these babies in reducing NICU admissions and reducing impairment at 2 years of age? So we want to only focus on babies here that the obstetrician is not comfortable waiting the full minute, the baby's not responding to stimulation, and now they need to either have their cord cut or milked. And we're studying those infants in our trial. And we're also looking at things like cerebral oxygenation, cardiac output in the heart, and looking at hemoglobin levels as well. And we'll also follow these kids using the Ages and Stages questionnaire out to 2 years of age. The way we're designing the trial, though, is because you don't know which babies are going to be sick. It's a design called a cluster crossover randomized trial, which is in our 10 hospitals that are participating. We are going to have half of them receive immediate cord clamping for 1 year, and then half will receive cord milking. They're randomized, and then we flip them. The next month, the next year, they retrain everybody, their obstetricians and staff, to then do the opposite, where they would then do, if you were cord milking, you would now do immediate cord clamping, and the same with immediate cord clamping, you would now do cord milking. And then follow these children out at 6 months, 12 months, and 1 year to then, 2 years to then look at how these outcomes are in these infants. So with cord milking, I think more study needs to be done, and hopefully we'll have more evidence to whether it's safe or can be used as an alternative. Meanwhile, for the last part of my talk, I wanted to talk about ventilation with an intact cord, because really, if we can ventilate all babies while they're connected to the cord or do delayed cord clamping, we don't need to use cord milking. And so that's the other part of where maybe the future is going. And so the idea is when you're ventilating with an intact cord, you're allowing lungs to open up and stabilizing blood flow. And the original study that spawned many of us to look at this was by Dr. Bott, where looking at preterm lambs, where they show that the lambs that were ventilated right away from birth had this nice stable heart rate shown in the white circles and nice stable right ventricular output as shown here by the white circles. But the lambs who were had their cords cut right away, and then they weren't ventilated right away, so they were just apneic, had a drop in their heart rate, a drop in their cardiac output, and you could see the same thing in carotid artery blood flow, and then it would come back up once they were ventilated again. So instead of having these up and down motions, you get this nice stable, flat stabilization of their hemodynamics if they're ventilated the entire time. So there was one sort of epidemiological study. This was done in New Zealand, showing that the babies who received 30 seconds of delayed cord clamping, if they were breathing compared to not breathing, the breathing babies had higher APGAR scores. They had less chronic lung disease, and they had less severe IVH. So not breathing during delayed cord clamping is actually bad. And so people sort of argue then we need to ventilate these babies. And so we designed a trial where we randomized babies to 1 minute of delayed cord clamping alone and 1 minute of CPAP with positive pressure ventilation. We thought that we would see a difference, and we saw no difference. We saw no difference in their hemoglobins, IVH, BPD, no differences in their delivery room oxygen or pressures that they needed. Everything was the same. So, we were very sad by the results of no difference, but it did teach us something, which is we learned that babies who are receiving CPAP compared to just stimulation alone take the same amount of time to start breathing, because we videotaped, as I showed you there earlier, these babies as they were receiving the CPAP or they were just receiving stimulation. And we saw that at 20 seconds, only about 40% of these babies were breathing. By 40 seconds, it was about 70%. And by 60 seconds, 90% of the babies were breathing. So really, it just takes time of stimulating the infants and allowing them to breathe before they'll all mostly start to breathe by a minute. And I think it gives good rationale that at least going to a minute is probably a good thing for these infants to ensure that they're all starting to initiate spontaneous breathing. And there was no difference when we looked at the 10% of the babies who weren't breathing in regards to if they were more premature or if they had anesthetic on board. It was highly variable. So I think for most centers, one of the biggest take homes I would say from this talk is focus on stimulation for these babies, encourage them to breathe while they're receiving delayed cord clamping. And so when we think about the preterm baby, we know that there are a number of issues for why they may not breathe. One of them might be just they're commonly delivered by C-section. And what that means is that many of these mothers don't have labor, so you don't get the benefit of a catecholamine surge, poor clearance of lung liquid, and also these babies themselves have weak intercostal muscles and poor respiratory effort. They just need more time to start to breathe. So when we think about resuscitation on the cord, we know that they might need a longer amount of time before they're starting to do it. On the flip side, if we go longer while they're on the cord, we need to make sure that the maternal outcomes are still safe. That is, we know that 1 minute is safe from a study that was done in Colombia about a year ago showing that there was no increase in postpartum hemorrhage. But there was a study done by a group in Thailand saying that going longer might increase your risk of postpartum hemorrhage when they did multiple babies that were each given a minute before delivery. So that is something that needs further study in regards to safety. On the flip side, a term baby who's being delivered, who's not breathing well, is a completely different entity, which is in term babies, we know that vaginal delivery is common and they'll have strong uterine contractions. So there's going to be a good amount of placental blood flow to these infants. In addition, they should start breathing by 10 to 15 seconds. And if they're not, there's something wrong, that they might be acidotic or hypovolemic. So it's not a normal thing to just stimulate them. Placental transfusion for a longer time is normal. So you can go 5, 10, 20 minutes, and there's no harm to a baby by keeping them on the cord for extended duration. So this is a good group to do resuscitation on the cord, meaning you don't have any risk at vaginal birth, and you can go as long as you need to in these infants. And they might truly benefit just by being ventilated when they're apneic. So we had done a study, a very small one of 60 babies, where we looked at whether or not ventilating them and providing CPAP on these babies who are not breathing well by looking at babies who are at risk of resuscitation. The challenge is we would set up and randomize the babies right at birth, and some of them did fine. They didn't need resuscitation, as you can see. In fact, more babies that received 5 minutes of delayed cord clamping only needed some stimulation compared to the early clamping group, where a higher percentage of them needed it. Now, it's hard to know whether the delayed cord clamping made them need less resuscitation. It could be. Or this should have just been a chance finding. The important thing is we did see some physiological differences in these babies. The ones who received the delayed cord clamping had better blood pressure, better cerebral oxygenation, lower oxygen extraction, meaning they had plenty to deliver to their tissue. And there was a trend of an increase in the hemoglobin, although not statistically significant. So it can be done. I think part of what I want to emphasize, though, is while it's possible in a research environment, it is not very easy to do. So the feasibility of ventilation, this is from one of my researchers that drew these cartoons, showing that in the operating room, when you're using a little trolley or a bed that we use for the study, you have 2 obstetricians, an OR tech, and your job is to fit in right between these guys to do a resuscitation, really by yourself, because there's not a lot of room for the staff there. And at a vaginal birth, it's the same thing. You have parents around the baby, nurse, and then between the mother's legs is the OB, and then you have to fit in the trolley. So it is a quite crowded space. And when we surveyed providers that when we did this resuscitation with an intact cord, while the parents very much liked this, you could see here from the graph, there were some people that had concerns about providing resuscitation or impeding care. It wasn't a large amount, but something that is worth noting, at least here in the United States, where we have busy obstetricians and the mothers are trying to deliver fairly quickly. It's not the best environment necessarily yet in terms of the logistics of having this as part of a routine care. And part of that is when we compare the original studies out of England, where they deliver the babies and have these Life Start trolley beds next to the mother, it's much easier to resuscitate the infant. And they also never break down the bed. Here in the United States, we are always putting the mothers in the stirrups, and then the obstetrician has to come in, and there's not a lot of room here in our current setup. So part of what we need to do is, if we're going to implement this, and there have been some now good quality improvement projects that have been published out of England showing how to improve compliance and being able to do this. But I want to make sure, at least from a take-home point, that this is not a easy thing to do, that you just go and buy a bed and everybody's going to receive this delayed cord clamping on the cord. I mean, with a resuscitation. So just something to think about while you're implementing this. The other part is too, is we envision, okay, we give the baby CPAP and boom, their lungs will open up and we'll see exactly what they saw in the animal data. The problem is, this is what we think is happening, but in fact, in the lamb, this is what they did, right? This was a lamb that was intubated, anesthetized. They put the flow probes in here. The lamb has no ability to breathe on their own, and every single breath is going into the lung. And the challenge is, in real life, that's not what happens. So when you're only doing it for 60 seconds, you can see that when they've done respiratory function monitoring, meaning every time you give a breath, is it actually going through? And you can see here on the left, this is an example of a sustained inflation where you're seeing all these breaths going in. But here on panel B, you can see that while the breath is being given, there's very few times where the air is actually entering the lung. And so one of the concerns is the glottis. The airway oftentimes is closed early in resuscitation. And so we might even need more time to allow these babies to breathe. Sometimes just by putting the mask on the face, the baby stops breathing. So we might actually be harming the baby by putting a mask on a baby who might be breathing well. And we saw some of this in our own studies. So we still need to think this through before we're going to be doing this on every single infant. In addition, when we think about a percentage of babies requiring or receiving delayed cord clamping, we saw that, again, the studies that were done with short durations, 30 to 45 seconds, had better compliance. But as they went from 60 to 2 minutes, the compliance drops, meaning it's harder and harder to make sure that all the babies receive the intended time if the time keeps increasing. So I understand that, physiologic based cord clamping, we want to go as long as we can to make sure the baby's breathing, which is great and a great concept. But if the babies aren't getting it because everyone's too nervous, then you can't study it properly. So part of my plea to people that are going to be researching this is to make sure that you're going to have good adherence to these longer durations if you're going to go further and further out. So part of my take home is to think about the pros and cons of delayed cord clamping and resuscitation. That is, delayed cord clamping and doing it in front of the mother, it promotes bonding. It's very physiologic. We saw that from the animal data and even some of our own pilot data. So that's the positive. The negatives are there are challenges still with cord length. There are some babies where the second placenta is more posterior. You may not always be able to get to that baby. There's also no maternal safety data for prolonged delayed cord clamping. We need good data if we're going to go to 3, 4, 5 minutes in these infants. And then the other part that I think I feel most strongly about is that we spent the last 30 years in neonatology doing good resuscitation. We put ECG monitors on the baby, pulse oximetry. We titrate the oxygen so they don't get too much or too little. We monitor their pressures to make sure we don't overinflate the lung or underinflate the lung. Make sure we have a good seal. Now all of a sudden, you're resuscitating the baby by yourself in this crowded room without any space, without any monitoring. Is that necessarily better for the baby just to keep the cord connected? Or is it better just to let the baby sort of be stimulated and start breathing on their own and then bring the baby over when they're stabilized to a proper panda bed warmer where you can then do everything you need to do for the baby? And I think that's what we need to think about with research moving forward is, how do we bring all the technologies to the infant where we can still do the same quality of the resuscitation? How do I bring my staff in where my nurse, my respiratory therapist, or the people that are going to be helping me for the baby are going to be able to be present as well? And I think that's where the future needs to go before we recommend this. So to sort of wrap up, I think providers must remember that the sickest infants are most likely to benefit from a placental transfusion. And I think while resuscitation with an intact cord has potential benefits, waiting at least 1 minute will allow almost 90% of all babies to start to breathe. And I think we need more studies before we can say with resuscitation, intact cord should be standard practice. Studies that actually show benefit in reduction in things like mortality, IVH, but that have good adherence to protocol. And there are some really good studies. There's one being done here in the United States called Vent First There's another one being done in Europe that's called the ABC1 trial. And I think these studies will allow us to have more information about, okay, if I show a benefit of keeping this baby on the cord longer than a minute and do more resuscitation there, that baby will have better breathing, maybe not need to be intubated, maybe have lower IVH rates. Then you can start telling people, okay, a minute's not enough, we need to go longer. Right now, my plea to most of you is to focus on getting all of your units to wait 1 minute before clamping the cord. Even in the baby who's not breathing right away, stimulate those babies, get them to start to breathe on their own. And I think you'll see better benefits in these infants than focusing on trying to give every baby 5 minutes of delayed cord clamping with a fancy bed, et cetera. We need to focus on the sickest kids getting it first. And I think looking at those babies in your hospitals will probably give you the biggest benefit in terms of reducing morbidity in your own practice. So with that, I just want to thank my wonderful research team and our sponsors. And again, thank you for inviting me to come speak today. I hope everyone is being safe during this pandemic. I hope to see you all one day in person in the future. Thank you very much.